we're so glad to have Dr. Paul Thornton with us. We were introduced to Dr. Thornton when one of our Timothy syndrome children went to him to be evaluated for hypoglycemia. And he's become such a wonderful and dear friend to the TSA as well as to me personally, because he's helped with other doctors understanding this incredible problem with hypoglycemia. He's done webinars with her, at least virtual visits with doctors in other parts of the world and country. And we're so grateful for his willingness. I wanted to just tell you that he is Ireland born and did his medical research or medical education in Dublin. His postdoc training was done in London and at the Children's Hospital of Philadelphia before he became director of the Congenital Hyperinsulinism Center for the Cook Children's Medical Center. I was interested when I was reading his autobiography sketch that his mother influenced him. She said to him that she must always listen to the mothers. I think this is critical. If more of our physicians would listen to the moms about all the things that they observe in their children, we would progress a lot faster and a lot further. Paul is a wonderful listener, but he's also very well known for his kindness and general care of the children that he sees. He has developed for us protocols in order to be placed in emergency rooms for the care of our Timothy children should they have these very unusual, unknown kind of fluctuations in their blood sugar. So I would now like to introduce you to our friend, Paul Thornton.
Well, thank you so much, Catherine. It's very kind of you, and that was a lovely introduction, and you make me sound a lot better than I really am, so I really appreciate that. All right, let me see, can I share my screen? Okay, so that's just my backyard. You can see there after a rainstorm. Let me get my slides up. Okay, can we all see that?
Mm-hmm.
Good. All right. So today what I wanted to do is talk to you a little bit about, what's new in terms of hypoglycemia since we all met. I met many of you over the last couple of years. And I learned a lot from you. And what I'd like to do today is to, again, update a little bit about what's new, talk about the association of hypoglycemia and Timothy syndrome and understand the possible causes of it and identify what needs to be done next. So my first slide here is really, how much new things have come out. And sadly, the answer is from an endocrine hypoglycemia perspective, very little. We've seen the British experience has been published where they reported 6 children over 24 years. And they reported the incidence of Timothy syndrome, therefore, to be 1.5 per 100 million of the population. However, they also reported that it is most likely that they are missing a lot of children because this was a retrospective study and it was done basically through the centers who participate in the arrhythmia studies. There's been some basic science papers looking at expression of the mutation and particularly the calcium channel. And from my perspective, something of interest because, with my interest in hyperinsulinism, we're more interested in the 1D variation of the alpha subunit. And there's been some more reports about that association of that mutations in the gene encoding the 1D with autism and epilepsy, neurodevelopmental delay, and hyperaldosteronism. Now, for those of you who are not familiar with hormones, hyperaldosteronism is a condition in which the adrenal glands make too much aldosterone, and aldosterone causes sodium retention and potassium wasting. And so in conditions of excess aldosterone, you get high sodium retention in the body, leading to hypertension and low potassium. So really, there's been almost nothing about hypoglycemia published. So let's look a little bit at the British experience, because we'll talk a little bit about some of the US papers later. But they reported a cohort of 6 patients, 4 males, 2 females. Interestingly, 4 of the 6 were premature. And at the time of writing the paper, 66% of the kids, and actually now adult, had survived. And, you know, they talked a little bit about the course for those kids. One 15-month-old had a cardiac arrest associated with gastroenteritis and survived. Another had a cardiac arrest and died at the age of 2 and was noted to have normal glucoses. And then the 24-year-old lady who, I don't know, is she on the call today maybe? Is she still alive? Because this was written a couple of years ago, who's diagnosed at 1 year of age. And then another more classical tragic story of a 13-month-old boy who died during surgery for syndactyly before they realized what he had. And then the twin boys who are mosaics. And for those of you who don't know what that means, it basically means that not every cell in the body is affected by the gene defect. And both of those have some problems. But what I thought was interesting is one of the twins is growth hormone deficient. And we'll talk a little bit about why that might be important later on. But basically, since we last sort of talked about the experience and information, there hasn't really been a lot. So, you know, the last big publication was this one that looked at patients reported from January of 94 to April of 2016 from 12 international centers, 17 patients, 88 male, 88% of them were male. They've been followed for approximately 5 years with a range of 3 to 19 years. And 39% or 7 of the patients had hypoglycemia. And all of the patients at some point in time were treated with beta blockers, and 77% of the patients were alive at the end of the study. And they did go into some of the hypoglycemia problems, and they talked about how 2 patients had episodes of ventricular tachycardia precipitated by hypoglycemia. 1 patient had a sudden cardiac death after developing VFib associated with hypoglycemia and general anesthesia. And 1 patient had hypoglycemia and seizure and subsequently went into VFib and died. So, you know, this raises the questions of, you know, is the hypoglycemia specifically triggering cardiac arrhythmias, and how might that be? And then, of course, the previous experience everyone is very familiar with from 2004 was again about 17 patients, 41% survival rate at the time of publication, with hypoglycemia occurring in about 36% of the patients, and a clear thought at the time that hypoglycemia led to the death of 2 of the affected children. So, you know, hypoglycemia is tragically interwoven with the, you know, most severe adverse events of Timothy syndrome, the sudden cardiac arrhythmias and sudden cardiac death. And the question is several-fold in my mind. You know, one is, why can hypoglycemia cause such problems? And number 2 is, why is there such a high rate of hypoglycemia in these children? So it's important for us to understand a little bit about how hypoglycemia occurs and how, more importantly, our bodies try and prevent hypoglycemia. Because I think sadly at the end of the talk, you're going to hear me say that, we don't know fully why these children are getting hypoglycemia. And the best thing we can do is to try and prevent hypoglycemia at this time until we have better knowledge. So it's very important for us to understand how hypoglycemia occurs. And so typically, when we eat a meal, the blood sugar rises, and any extra sugar that we're not using for energy use at that time gets stored as glycogen, primarily in the liver, but also in the muscle and in the brain, or it gets converted to fat, where that fat can then be used as a form of storage for energy, such that when we're in a state of fasting, we can then get that energy out of the fat cells or the adipose tissue. So once the meal is over and we start fasting, the first thing we do is remove the sugar from our liver stores of glycogen. And typically, that can last anywhere from 3 to 4 hours up to 8 to 10 hours in perhaps an adult. And then once we've used up all our liver glycogen stores, we start making glucose. And we're able to make it from lactate and amino acids. And in fact, there is a cycle whereby we release amino acids like alanine from our muscle, and we convert it into lactate that can be used then to generate energy. But again, it makes sense that you don't really want to be breaking down your protein, because that would be your muscle and things like that, when we have a much better energy store known as fat or adipose tissue. And so really, once you start using up all your glycogen, now you start breaking down your fat stores, and you break down those triglycerides and you make them into free fatty acids and glycerol, and two molecules of glycerol can be converted into 1 molecule of glucose, and the free fatty acids can be broken down into essentially ketone bodies. The primary ones we use are beta hydroxybutyrate and acetoacetate, and these can all then be used instead of glucose by almost all cells of the body. And in fact, the heart is very efficient at using those. So, this is all regulated by hormones. So when we're in the postprandial or the post-meal phase, the primary hormone we have is insulin, and that rises after a meal. And insulin's function is to help cells take up glucose and to drive the manufacture of fat when we're in a position of excess energy. But once the glucose level starts to fall, after that sugar in our meal is absorbed, we then start to see the insulin level falling. And when our blood sugars get down below 80, we really get into switching off insulin. And what insulin levels falling allows the effect of glucagon and epinephrine or adrenaline, if you live in Europe, to rise. And this prevents the fall in glucose by stimulating glycogen release from the liver, but also by starting the process of gluconeogenesis, which is making glucose from proteins, and ketogenesis, which is making ketones from fat. And then cortisol and growth hormone levels start to rise, and they also stimulate gluconeogenesis and fatty acid oxidation. So you can see that there are, a careful interplay of food being eaten, hormones changing, and metabolic adaptation to fasting that allows the cells that need to use primarily glucose as fuel to use the glucose, but all the other cells that can burn fat and use lactate to be able to use that. And so you can imagine if any of these things go wrong, that we could therefore have hypoglycemia. Now, what does hypoglycemia look like in our children? Well, there's a couple of things that are important to remember. There are 2 types of hypoglycemic symptoms. The first type we call neurogenic symptoms, and these are the symptoms that really are a warning sign of impending hypoglycemia. These occur really before you become hypoglycemic, and they're designed to help your body fight the hypoglycemia. So these symptoms occur as a result of secreting epinephrine, norepinephrine, and these hormones. And so you get what we call the adrenergic symptoms of tremulousness, anxiety, tachycardia, palpitations, food-seeking behavior, and then some of the other things that we might have, episodes of pallor, sweating, hunger, and numbness. And so these are symptoms that are commonly seen in people as their blood sugar falls. But it's very important to remember that children under 5 are rarely able to report these symptoms. And looking at your child under 5, it's often very difficult to tell that their blood sugars are falling. And so symptoms themselves in younger children are not very useful. These symptoms are useful in older children and adults who are able to learn to recognize those symptoms and then do something about it. Now, more significant are the neuroglycopenic symptoms, and neuroglycopenia basically means that there is not enough sugar in the brain. And so these are symptoms that reflect dysfunction of the brain as a result of energy shortage. And so when the brain cells aren't working properly, they start to result in irrational behavior. In babies, they lose their ability to suck, so they have poor feeding, they become very lethargic and sleepy, and it eventually leads into confusion, disorientation, and then seizures, and then eventually coma. And so when we see these changes, that usually means that your blood sugar is significantly below 50, typically down in the 30 to 40 range in the United States, which would be about 2 to 3 millimolar in the UK. And typically this happens when your blood sugar has been down in that range for some time. And so this is a slide adapted from Cryer, where it basically shows that if you have a hypoglycemic condition or something like diabetes, that you want your blood sugar to be in a good target range, which is greater than 70 milligrams per deciliter or 3.8 millimoles per liter in the UK. When your blood sugar is between 50 and 70, this is a time of caution. And this is where all of the neurogenic responses of glucagon, epinephrine, cortisol, and growth hormone start happening, giving you the neurogenic symptoms, all with the goal of preventing you from getting into the danger zone where the brain is no longer starting to function. When you get down around 30 or 1.6 millimole in the UK, this is where the brain glucose levels at a plasma glucose of 30 get down to almost 0. And so when you get below 30, this is where the real serious danger occurs. Now, when we think about kids with hypoglycemia and we're trying to determine why they have hypoglycemia, the history is very important. Again, you have to listen to the mother, like Catherine reports my mother is saying. But the most important thing is, when did the child last eat? And so if I see a child who has a low blood sugar, I want to know how long has it been since they're eating, because that really tells me which system is not working. So if it happens within a few hours of eating, less than 4 to 6 hours, that suggests that maybe there's a problem with insulin, there being too much insulin, or maybe there's a problem with getting the glycogen out of the liver, such as you would see in the glycogen storage disease. And if it happens, 6 to 12 hours after we eat, that could suggest a milder problem with insulin not switching off as the blood sugar is falling. But it also could indicate a problem with the counter-regulatory hormones that come from the pituitary gland, such as cortisol and growth hormone. And it could indicate a problem with gluconeogenesis, where you're not able to make glucose out of lactate or out of amino acids. And then when it happens long into fasting, 12 to 24 hours or longer into a fast, now we're talking about problems such as an inability to be able to break down your fats. So that could either be because you're not able to break down the fats because you've got cortisol or growth hormone deficiency, but it also could be because you've got an enzyme breakdown in fatty acid oxidation. And rarely the disorders of gluconeogenesis will cause you to go low, 12 to 24 hours out. So that's one of the first things that we look at as a historian is when does the hypoglycemia occur? And so obviously, you could probably guess that we could make anyone hypoglycemic if we fasted them long enough. So another thing that's very important for you guys to know is that not only are there pathological causes of hypoglycemia, meaning hypoglycemia caused by specific diseases, but if you simply don't eat for a long period of time, you will become hypoglycemic. However, in the normal individual, that hypoglycemia will be associated with an elevation of ketones, and the brain, for example, can use ketones as a fuel and protect the brain. So we'll talk a little bit later about, prevention of hypoglycemia in our kids, and part of it depends on if we can find an underlying cause for the hypoglycemia, and the other part depends on understanding what normally happens and how intercurrent illness causes us to burn up our sugar much faster and use our fuels quicker, and so we can get to that point of hypoglycemia sooner. So how could Timothy syndrome be associated with so much hypoglycemia? Because as you're all very familiar, calcium channels are all over the body, but the genetic defects in Timothy syndrome cause a problem with the alpha subunit, the 1C version of this. And so the problem is that in the pancreas, insulin secretion is generally controlled by the CACNA1D subunit. So what we're learning is that in theory, it all seemed very simple. You had a mutation in one form of the protein is expressed in certain places, and mutations in another form of the protein are expressed in different places. But it turns out that all these channels many times are expressed in the same tissue. So it's very possible that that although insulin secretion is controlled by the 1D version of the protein, it's possible that there could be some overlap. And so, there has been a couple of cases of children with hyperinsulinism described with mutations in the CACNA1D gene. And they also had some problems with other parts of their body. So there's clearly some overlap going on. But it turns out that these genes are also expressed in the pituitary, where cortisol and growth hormone secretion are controlled from. Growth hormone is directly secreted from the pituitary, but cortisol is secreted from the adrenal glands as a result of ACTH stimulating the adrenal glands, which is secreted in the pituitary. So now we know from expression studies that tissues in which calcium plays an important role in signal transduction and hormone secretion can have both the CACNA1C and the CACNA1D variants of the calcium channels, and it's possible that there's some overlap that's occurring. We also know that in Timothy syndrome, lots of people are on beta blockers, and beta blockers can affect the ability of epinephrine to raise the blood sugar. So in populations of people who take beta blockers, the rate of hypoglycemia has been shown to be about 1 to 3%, which is way above the rate that would be seen in the normal population, but yet it's nothing like the rate seen in the Timothy syndrome. So it's unlikely that beta blockers alone are the cause of hypoglycemia in Timothy syndrome. And what beta blockers really do is they prevent hormones from causing the blood sugar to elevate. And so as you starve and don't eat and your blood sugar falls, you're not able to counter-regulate and balance that as well. And so the simple solution when you take beta blockers is don't fast for very long times. So then the second thing that's, really interested me over time is, how can hypoglycemia cause sudden death? Because when we look at all the reports, a lot of times we see that many patients don't appear to have a history of a lot of hypoglycemia, but hypoglycemia appears to be occurring at an end stage in their lives. And so, people have looked at how does hypoglycemia cause sudden death. And when we give rats insulin in high doses and produce profound hypoglycemia very quickly, where the body is unable to balance it out, we know that we can induce seizures in those rats that will cause a respiratory arrest. And we know that we can induce arrhythmias that will cause a cardiac arrest. And when those rats were given a beta blocker alone to try and prevent the arrhythmia, or an anticonvulsant alone to try and prevent the seizures and thus the cardiac arrest, there was no change. But they noted if they gave both, that the survival rate in the rats increased up to 100%. Now, the problem is, this study was not set out and designed to show the effect on long-term brain damage, which I'm sure the beta blocker and anticonvulsant probably did not prevent. However, it did prevent the cardiorespiratory arrests. So that was encouraging news. And another study done by Reno and published in Diabetes back in 2013 was looking at, progressive hypoglycemia. So as you steadily drop the blood sugar down for 30, 60, 90 minutes, what happened? In other words, does it all happen right at the beginning, or, do you have a little time to intervene? And so what they showed was that with moderate hypoglycemia, you started to get premature atrial contractions and first-degree heart block with some ventricular tachycardias. And as the severe hypoglycemia progressed, heart rate increased. Now, we already knew that heart rate increases as blood glucose drops, because what our bodies are trying to do, and what the rats were trying to do, is pump more blood with lower amounts of sugar to the brain, so the brain could extract more sugar, because even though it was in low concentrations, more blood means more sugar. So, and this is a part of the neuroprotection that occurs in hypoglycemia, is to increase your heart rate. But as time went on, and as depth of the hypoglycemia progressed, this then developed into heart block, which of course then led to third-degree heart block and asystole, or the heart stopped beating. And what they also noticed was that like the heart rate increasing, the blood pressure increased initially, until eventually there was that terminal event, and then it dropped profoundly. And what they did show is that beta blockade did seem to help the outcome. But this was of the cardiovascular outcome. Again, it didn't look at the brain outcome. So the beta blocker probably stabilized the myocardium a little bit and prevented those arrhythmias. But again, they didn't address what happened to the brain as a result of the prolonged hypoglycemia. So, this leads us with a lot of unanswered questions. Number one is, nobody has yet determined consistently what the cause of hypoglycemia is in many of the patients with Timothy syndrome. And typically this happens because most of the kids don't have a history of having hypoglycemia every day, so you can go in and get a sample when they're well. But typically it seems to occur profoundly and severely when the child is having a cardiac arrest. And quite frankly, if I'm an emergency room doctor and I have a child having a cardiac arrest in front of me, I'm thinking about getting that heart going again, because rather than what's going on with the blood sugar. And so a lot of times when children have passed away and we go back and look back at the records, we don't learn anything from the records as to why maybe they had hypoglycemia. So the questions we have to determine is, in a given child, is it beta blocker, mediated counter-regulatory hormone, not so much deficiency, but the inability to respond to the counter-regulatory hormones? Is it calcium channel mediated insulin secretion? So somehow in the beta cells, when the wrong calcium channels are not functioning properly, does that allow calcium to be enter into the beta cell and stimulate release of insulin through the complex system that occurs. Because really, does the beta cell care if that calcium comes in through a CACNA1C or a CACNA1D channel? Probably not. It just cares that there's a change of calcium in the channel, in the cell. And then, you know, could the calcium channels in the brain moderate counter-regulatory hormone secretion, or could the calcium channels expressed in the adrenal gland moderate cortisol secretion in some form or manner? So, you know, how are we going to find this out? Well, obviously, if a child is having a low blood sugar, we clearly want our physicians to be worried about the heart and the cardiac rhythms and the breathing, but we also need them to focus on the hypoglycemia, and we need them to focus on two things. One is correcting the hypoglycemia, but if at all possible, try and grab a sample so that we can analyze what's going on in the blood that caused that low blood sugar. And so what we've recommended to all our patients is that you carry a letter with you, you know, amongst all the other information you have that, you know, basically tells the doctors, my child has Timothy syndrome, this is what it causes. We're at severe risk of sudden cardiac death. We have an implantable device. All those other things that you guys have to be prepared to tell a doctor who's never in his life heard of this, never mind seen a kid like this before. And then on top of it, you have to worry about what's my child's blood sugar. And so we recommend that you have a letter that basically says my child's at serious risk of having hypoglycemia that could trigger the cardiac arrhythmias. So we need to check the sugar immediately. If it's low, we need to draw some blood work and then immediately give some sugar water dextrose through the IV. And so, you know, this is just a list of the blood work that we as doctors would want to see when someone has a low blood sugar, because when we get all of these results back, we're able to take this algorithm that we have and we're able to use it to give us a clue to the diagnosis. So we look at some of these markers like the bicarb, the beta hydroxybutyrate, the lactate, the free fatty acids, and we can tell if there's acid levels are elevated in the blood or no acid levels. If there are acid levels and it's lactate, that makes us think about gluconeogenesis defects. But in your kids' cases, it could also be elevated because of inefficient beating of the heart, because of the arrhythmias. So we wouldn't want to jump to a conclusion. We'd want to look at the lactate in the setting of, you know, how well perfused was the child, or was their blood pressure very low. But if the ketones are high, then that tells us that the child is making ketones, but it also could be a sign of a glycogen storage disease problem or of growth hormone or cortisol deficiency. And then we look at the kids who've got no elevated lactate in their blood, and we want to see, do they have both low ketones and low free fatty acids, or low ketones and high free fatty acids? Because this is a very dangerous combination, because these high free fatty acids can cause cardiac arrhythmias when associated with carnitines. And so this is what we see in the fatty acid oxidation defects, is that these kids can have a sudden effect on the heart. And then if the free fatty acids are low, it makes us think there's too much insulin, or there's not enough cortisol, or some other things that happen to normal newborn babies. So the last thing we want to think about is, you know, how do we prevent death from hypoglycemia? Well, the first thing we have to do is prevent hypoglycemia. And this means that, you know, our children, we need to know how long our children can safely fast. And typically most kids can fast over 12 hours, but you want to be careful about going out to, you know, 14, 16, 18 hours. So we generally recommend just having a little bedtime snack before they go to bed, and then eating relatively soon in the morning. But more importantly, because remember, most of the reports have come back suggesting that these problems occur with intercurrent illness, be it gastroenteritis or upper respiratory tract infection. So when your children are sick, they need to have carbohydrate intake a shorter interval. So now you suddenly can't sleep overnight. You might want to wake them up if they've had a poor day of eating, and just make sure they have a sugar containing drink. It could be milk, it could be juice, it could be soda. this is not the time to worry about long-term health conditions of drinking too much, Lucasade as we used to drink in Ireland. Some of the British members, do you have Lucasade in Britain, or is it just Ireland? I think you have it in Britain too, don't you? And then the thing is, have a sick day plan. What are we going to do if our child has an intercurrent illness? How are we going to make sure that the fluids they drink have sugar contained in the fluids? And then from a research perspective, is there anything to be learned from the animal models? And should, everyone be on a beta blocker all the time? And, and that's more typically that question arises for the cardiac stuff. But, should people be on anticonvulsants? They're drugs with a lot of side effects. So please don't get me wrong. I'm not advocating this, but it's something we need to be thinking about and trying to understand is, could that help in these cases? In animal data, it helps, but would it help in a Timothy syndrome model animal data? So I think there's a lot of things we have to learn. So I think with that, I'll stop, and I'll stop sharing my screen and open this up to questions if anyone has any questions.